Hey,
Hi.
Dr.
Hi. Hi. How are you?
Good. How are you doing?
I'm like, do I have the right Zoom? Because it says something about 8 a.m. meeting when it
Oh,
popped up, FYI. So I was like, 8
that's
a.m.
weird.
Yeah.
I don't know why it says that. That's strange. I will have to look. But yes, you are in the right virtual place. Thanks so much for talking today. We're excited to hear it. We actually were just talking about hyper and hypocalcemia during our morning report. So I was like, stay tuned, everyone. There's more to come.
Oh, great. I didn't know I was getting I thought this would be kind of introductory, and since it's July, I thought I would first kind of do the basic stuff and then
Oh,
more.
yeah.
Okay.
I think that's great. That's great. It just came up because we were talking about altered mental status. So there was a lot of discussion of like, what can cause that? But anyway, I just have one question for you. How do I pronounce your name? Just so I say it right when I introduce
Yeah. Do you want the full? So it's Radhika Narla.
you. Radhika Narla. Great. Okay, cool. Well, we can do this however helps you best. I will be here the whole time. So I can help moderate like chat questions and just maybe like jump in and interrupt if there's something people are chatting about. If you want to do that yourself, that's also totally fine. I can like hold
I'm
it.
on one screen. Yeah, I'm on one screen, so I won't see the chat box once I share my PowerPoint.
Okay.
So if you can kind of watch it, that would help me.
Yeah, of course.
I kind of go over the basic stuff first, and then I do cases, and I ask people, hey, can you put in the chat box A, B, or C and D? And that's where I'll need help. Like I won't undo my screen to look at the chat, so I'll just say, Tess, what are you seeing in the chat box? And hopefully we'll get some. I mean, it's a hit or miss. I get when I've done this, then I get a lot of audience participation, and it's great. Sometimes everyone's nervous to put in their
Yeah.
answer choices. So we'll just have to see.
That's totally fine. That is definitely the gist that I've been noticing too. It depends on the group, how interactive people will be, but we'll try to keep people engaged, and I'll encourage people to unmute if they want or put it in the chat. Most people end up using the chat just because I think they're like on a computer with a team or something, which is fine. Yeah, that's totally fine. And then we'll just maybe leave some space at the end for questions if people have it. But otherwise, if you want to practice sharing your slides or something, we can do that. But otherwise, nothing
You know,
fancy.
I do Teams and then I do Zoom. So now I'm like, where is the share button on this? Okay. When you have to go through so many platforms, right?
I know, it's so much. All right, I can see your slides. It looks like, yep, they look perfect.
Okay. I'm going to stop sharing then for right
That's
now.
great. Cool. Well, it's 12:30, so I'll let everybody in and introduce you. And you're primarily at the VA, is that right? Okay, cool. All right. Welcome, everybody. Thanks so much for tuning in. I know we've got a couple people slowly filtering in. I'm sure more people will join us as the hour goes on. But I want to get us started on time so we have enough time to go through our cases and our whole presentation with Dr. Narla. Before we get started, I just want to introduce our speaker. We have Dr. Radhika Narla, who is an endocrinology attending within the UW faculty. She's primarily based at the VA right now. So some of you may get to work with her or see her when you do consults over there or are taking care of patients over on the wards. But she will be talking to us today mainly about calcium. So please feel free to unmute yourself if you have questions or put things in the chat box. Primarily, I'll kind of jump in and help us moderate that as well so we can get everyone's questions answered and keep everyone with us. All right, Dr. Narla, I'll let you take it away. Thanks so much.
Thank you, Tess. Let me reshare that screen. Great. And then I think that looks good on my end. Thank you, Tess, for that introduction. Yes, I'm one of the attending faculty, primarily based at the VA. I'm actually also one of your new APDs for subspecialty medicine. So you will probably see me more than just on the wards and the consult service. So I'm excited to work with all of you. My clinical and research interest is actually osteoporosis. And so we have a multidisciplinary osteoporosis team at the VA to help serve our veterans, where we not only look for risk factors for bone loss, but we also look for risk factors for falls. And so some of you rotate through that rotation as well. So excited to have you there when you come on over. So for today, we're going to, since it's early on in the year, I like to kind of review the basic fundamental pathophysiology that's really important when you try and understand calcium disturbances. You can't also just talk about calcium, you also have to talk about the other mineral, phosphorus. So we'll talk about that a little bit too. And I'll definitely review some of the positive and negative feedback loops, right, that we all have to remember, and the different hormones that regulate calcium and a little bit of phosphorus homeostasis, right, the parathyroid, active vitamin D, and introduce you to guys to FGF23 in hopes that you'll hear more about it from the nephrology colleagues. We'll take some of that pathophysiology, and then we're going to apply it to some practical clinical cases where I'm hoping to kind of highlight the initial workup, differentials, and diagnostic testing for hypercalcemia and a little bit on hypocalcemia. I do more of a focus on hypercalcemia, given that that's the most common one that you will see. I don't have a commitment after this, so I'm available and I'll stay on at the end for any questions as well. So with that, kind of taking a 1,000-foot overview of what we're talking about, right? Our body really does do a good job of regulating calcium and phosphate levels, very important minerals in our body, right? Our calcium is needed for action potentials, muscle contractions. Phosphorus is also important in that it's needed for, your DNA, RNA, ATP. And you can't just talk about calcium without mentioning phosphorus, since they like to complex together, especially in the bone. But there are 4 major organ systems that regulate your concentrations of calcium and phosphate to keep them in check. So they are the GI system, obviously the parathyroid with the parathyroid hormone, and we'll definitely talk about that. The skeletal system, so your bone, and then your kidneys. And so there's a lot of interplay between these organs that helps to maintain the balance and concentrations of calcium and phosphate. As again, kind of a global picture overview, right? You take in a certain amount of calcium and phosphorus in your diet, right? Some mostly through food, some supplements. Some of that is excreted and some of that is reabsorbed into the plasma. And there's this phenomenon where you've got this constant exchange or bone turnover that's happening with your bone. Calcium and phosphate is stored in your bone. And so if you need it, then it's also released from the bone. So you've got this bone turnover where you got bone formation happening and bone breakdown or bone resorption happening. And then finally, the calcium and phosphate in your serum is filtered, right, by the kidneys, with some of it being reabsorbed and some of it is excreted in your urine. I put here the numbers for calcium. You take in ideally up to about 1,000 milligrams of calcium in your diet. And even with, it varies a little bit between a man and a woman, but most of us will still excrete at least about 150 to 300 milligrams of calcium in our urine. So just keep that number in your back of your head. Some other fundamentals just about calcium itself. Again, calcium and phosphate like to complex together as hydroxyapatite in the bone. And so that's a major storing site there for those 2 minerals. With the rest of it, with 45% of it being in the physiologically active form or that ionized form. And then the rest of it is bound to your proteins, your albumin and so forth. And so key pearls right away. A few years back, the BNP or the chemistry panel added the total calcium, just the serum calcium. You don't get ionized calciums on everyone because it's expensive to run, as well as it has to be handled a certain way by the laboratory medicine folks. And so for practical purposes, you just get that total calcium right away in the serum. And so with that, one thing to keep in mind is especially when you have patients that you're seeing or you're called on by other colleagues and they've been in the hospital for quite some time, right? They can have low protein stores and so they can have low albumin. And so before you start working up a patient, because you're seeing the serum calcium coming back, let's say 6.8, you wanted to make sure you look at the albumin, right? And correct it for that low albumin, because maybe then the calcium is actually at the lower limit of normal and you don't have to go down the whole workup. Likewise, if you're dealing with a hypercalcemia patient, let's say for the sake of argument, it's 11.4, the calcium, and the albumin is actually low, like 3, when you correct for it, the corrected calcium may be even higher, so like 12. And so then your sense of urgency kind of changes, right? So definitely the first thing is looking at that albumin and seeing what kind of corrected calcium you're handling with your patient. The other thing I like to mention, especially to my endocrine fellows, is that, I'm not talking about the calciums that come back 11.3, 11.4. I'm talking about the calciums, if your reference range in most laboratories is a normal calcium is 8.2 to 10.2. I'm talking about those calciums that come back like 10.3, just a smidge little high. In endocrine, you're going to notice we always repeat our labs a couple times, and we repeat them because sometimes it can be falsely, erroneously high. And that's sometimes because the lab technician left the tourniquet on too tight. And so often I repeat those 10.3s and 10.4s and they come back normal. So just something to keep in mind, just for the borderlines, not the higher calciums like 11 and so forth. And finally, another thing to keep in mind, especially on the wards, if you have a patient with an acid-base disturbance, like they're on the vent or something, and let's say they're acidotic, right? These binding sites on albumin can bind hydrogen ions and calcium ions. And so if they're acidotic with a low pH, hydrogen binds onto here and displaces the calcium. And so then your ionized calcium can temporarily increase. And so when you're interpreting those ABGs, it's important to see what is the acid-base status, because if you correct it, then your ionized calcium will come back in that normal range. So just something to also keep in mind as another factor that can affect your calcium. And then briefly, like I said, calcium and phosphate like to complex together, and it does as hydroxyapatite in the bone. A small portion of it is in your serum as phosphate, and that's what you check when you check a phosphate level. I'm not going to go into it in depth, but it is important, and hopefully by the end you get to appreciate that there's a lot of crosstalk and cross communication between calcium, phosphate, and all the hormones that regulate them. I know a lot of people have not heard of FGF23, but it's an important hormone that we're learning more and more about. And its major job is to decrease serum phosphate and decrease active vitamin D or calcitriol. And in the next slides, you'll appreciate why I do have to mention phosphorus and FGF23, because there's a lot of kind of this inner communication between them when they're dealing with calcium. So to summarize the major actions of the hormones before I show you more finer details, right? The parathyroid hormone. The parathyroid hormone is the major hormone that regulates calcium. And so if you have a low calcium concentration, the first job is PTH goes up, and its job is to increase calcium and decrease phosphate. So why does the arrows go in the opposite directions? Well, remember, I've emphasized that calcium and phosphate like to complex together. And so if PTH's main job is to increase the net calcium concentration, it's got to make phosphate go in the opposite direction. Okay, so keep that in mind in terms of the arrows. Whereas calcitriol, or active vitamin D, or also called 1,25-dihydroxyvitamin D, it's not the main player for calcium. It does do a good portion of the role, so it's more like a supporting character. And what active vitamin D does is it increases calcium and increases phosphate. And finally, while FGF23 has no direct role in calcium, it does work to decrease serum phosphate and decrease active vitamin D. It's important to keep track of all of these arrows, because probably some of you already appreciate when you are, working up a patient and one of these are the issues and disturbances, it'll help you narrow the differentials down to say, where is the abnormality, or which hormone do I need to worry about, and so forth. And so even us, we kind of still think like this in terms of the feedback loops and so forth. And then finally, you guys are probably already starting to appreciate, right? Vitamin D has so many different names, and it is confusing because I will interchange and say active vitamin D. I might say calcitriol. I might say 125 dihydroxyvitamin D. But it's important to keep track of which form of vitamin D. And hopefully I'll have time to show you, like for a Hypopara thyroidism patient, it's important to know which vitamin D to prescribe. And so that's why it is important to keep track and to get used to the nomenclature. Okay. So we've kind of, I've built some of the foundational layers, and we've kind of talked about some of the basics of calcium and a little bit of phosphate homeostasis, as well as the 3 major hormones. I'm going to put that all together and talk about what happens when you have low calcium, and what happens with the hormones and the feedback loops and the different organ systems, and try and bring this all together. So you get low calcium concentration, and the first thing that happens is there's something called calcium sensing receptors in your parathyroid glands. And it says, hey, the extracellular concentration of calcium is low. We need to increase PTH secretion. And so PTH is increased from the parathyroid glands. And so where does PTH go to act to increase the calcium concentration? Well, first it goes to the kidneys, and there are calcium sensing receptors on the kidneys. And it says, hey, when you're filtering the urine, you're going to reabsorb all the calcium back into the serum, and you're going to excrete very little calcium in the urine. So that will help bring up the calcium concentration. The second point here is that PTH here works to say, hey, you're going to excrete all that phosphorus in the urine so that my net calcium concentration goes up. Remember, we don't want to increase phosphorus as well here, otherwise it'll just complex together. And so you're going to get an increase of phosphate excretion in the urine. The next thing is, if you guys remember, there's that 1-alpha hydroxylase enzyme, right, in the kidneys again. And that helps to convert inactive vitamin D, or calcidiol, to calcitriol here, as written as 125 dihydroxyvitamin D. And so PTH activates the 1-alpha hydroxylase enzyme so that you get more active vitamin D. And so what does more active vitamin D do? In the GI system, you need active vitamin D as a co-transporter to bring in more calcium in the gut. So then that increases your calcium gut absorption, and again, increases the calcium concentration. Finally, so we've done the kidneys, we've done the GI system, then there's the skeletal system, right? So PTH, through a complicated mechanism, causes an increased breakdown or resorption of your osteoclast cells, where you get the bone breakdown and you get the increase in calcium. Some phosphate, right? Because it's complex together. But remember, with PTH acting on the different sites, the net is increased calcium, decreased phosphorus. And then finally, the activated 125 dihydroxyvitamin D here also goes to the bone and says, hey, osteoclast, let's break down some bone to release that calcium and phosphate. So the net effect, again, is increasing this calcium concentration. And so now that the calcium is going up, it's saying, oh, calcium sensing receptor, the calcium has gone up. We probably don't need as much PTH. So there's one feedback loop system. The other thing I want to mention is you've got the increase in active vitamin D and the increase in PTH. They both feed back to the FGF23 hormone, okay? And they both activate FGF23. And so what does FGF23 do in all of this? It actually goes to the kidneys and says, you're going to excrete all that phosphorus in the urine, right? Because we want to decrease that serum phosphate level. And so it inhibits your sodium phosphate channels in the kidneys, and then decreasing the serum phosphate level. And in endocrine, we have all these feedback loops, right? And so once the phosphorus levels at a certain level, FGF23 says, hey, we don't need more 1-alpha hydroxylase or more 125 dihydroxyvitamin D, and we don't need more PTH. And so then it goes and gives that negative feedback to both the other hormones. I hope this helps to put it all together. It can get complicated with all the feedback loops. But it's a very nice checks and balance system that happens to really regulate your calcium. And so now with this, we're going to go into questions where what happens when some part of this is off or when the parathyroids are misbehaving. And so we'll talk about that with the case example questions. Okay, so here's the first case. She is a 65-year-old female whose only main medical conditions is hypertension, and she does have a distant history of papillary thyroid cancer. She underwent thyroidectomy and radioactive iodine many years ago and tells the ER doc that she's on levothyroxine and there's been no evidence of recurrence. She came into the ER because this is just unusual. She's feeling very tired, not really eating that much, and she's nauseated and throwing up. Her medications are just 2 antihypertensives and levothyroxine. She's not on any calcium supplements, and she says there's no family history of any endocrinopathies or calcium disorders. And the ER physician, while they're telling me about this patient, says, hemodynamically, she's stable. Based on Epic, her weight is down about 7 pounds in the last 4 months. She looks a little bit in distress, but otherwise there's nothing on exam, and he doesn't palpate a thyroid or anything like that. And so the ER doc starts reading a bunch of labs to you. Okay, and so I want you guys to take a couple seconds to kind of look through these labs, and in the chat box, and Tess is watching the chat box for us, tell me which labs stick out to you. Just, you can call off whichever labs are sticking out to you that looks abnormal and that we need to talk about.
We've got an early vote for calcium.
Calcium, yes, calcium is 11.8. And like I said, usually that is not a falsely elevated calcium level. And so that's good. So, and let's just say for the sake of argument, we've confirmed it. It's a true hypercalcemia. So what's next? The TSH is low, good. So you've got a TSH is low. What else? What other labs stick out at you that we've kind of talked about already a little bit that you should look at? Anything else that sticks out to anybody? A normal T4, good. So we have a TSH is low, but an active T4 that's normal. So good. And we'll talk about that. Albumin isn't the low end of normal. Great. Yes. So you've got the calcium. Your eyes should turn to the albumin. Very good. And so it's at the low end of normal, but it's not low. So you'll definitely just double check with the calculator. Good. Creatinine. Yes. Thank you. So let's just say this is a new acute kidney injury. And so this patient usually lives at a 0.6 or a 0.7. And we'll talk about that this can happen, especially with hypercalcemia that requires a presentation to the ER. So good. And I closed my chat box accidentally, but phosphorus is at the low end of normal, but it's at the lower end of normal. So keeping your arrows in the track in your head. So good. So what is the next lab that you want, or you want to hear the ER doc has ordered? What do you guys think? PTH, yes, thank you, Matt. Yes, that is after you've confirmed the hypercalcemia, you've corrected for the albumin, the PTH level is very important in kind of your branch point decision making here to decide which way am I going to go in the differentials, as well as ultimately management and so forth. So good. And so when you're talking about the PTH level and you're working up a patient with hypercalcemia, if a patient's calcium is high, their PTH should not be elevated, or it shouldn't be like a normal level. And we'll talk about what this abnormally normal means. So if you're dealing with a high or elevated PTH or abnormally normal PTH, that means there's something going on in the parathyroid glands that's causing the hypercalcemia. And so that's something we call, or often refer to, PTH mediated. Most often it's one parathyroid adenoma that's misbehaving. You can also see like 3-gland hyperplasia, and that's very rare, but you can see an inactivating mutation of the calcium sensing receptor that we talked about, where it's not sensing the extracellular calcium concentration and it keeps secreting the PTH. And obviously, if the calcium is high, your PTH should be low, right? The PTH should not be secreted. And so if it is low or suppressed, then you can confidently say, okay, this is not a parathyroid issue. It's a non-PTH mediated pathway that I need to go down and think about for my differentials. So good. And so let's go a little bit deeper into that case. And let's just say, for the sake of the argument, calcium is confirmed 11.8, and the PTH, the ER doc already got, and it's 45. And the reference range I listed here, and the reference range can vary between the 3 training sites. I've put the most common one that I've seen, which is PTH level of 10 to 65, okay? And again, for the sake of the argument, and we'll talk about why did I get 24-hour urine collections on this patient. Let's say that the 24-hour urine calcium came back at 196 milligrams. I got the creatinine excretion to make sure that it's an adequate sample, and it is. And I calculated this calcium creatinine clearance ratio, and it came back at 0.015. Now, I purposely made this not clear cut. It's not always going to be like this. And I don't expect you all to know right off the bat the answer, but if you had to tell me right then and there, you had to tell the ER doc what you think was going on with the patient, your best guess, would you say A, this is familial hypocalciuric hypercalcemia? Would you say B, this is hypercalcemia from too much thyroid hormone and we need to reduce the levothyroxine? Would you say C, you're worried that this is hypercalcemia of malignancy? D, this patient has primary hyperparathyroidism? Or E, you still can't tell and you need some more labs? What do you guys think? Anyone want to take a stab at it? Food coma settling in, lunchtime. Tess, do we have anybody with volunteer?
I'm seeing, oh, someone is guessing B, and then someone else is now guessing D.
Okay.
Different answers. Okay. A couple of votes for D.
Good, good. Great. This helps me out so I can kind of go through each of the answer choices. And so if I was asked this question, I would probably say my clinical assessment and best guess, it is D, that it is a patient with primary hyperpara. And so let's talk about why it's not the other choices. Why did I get these 24-hour urines? And what is FHH again, right? So first, I think I want to make sure that I emphasize this because this often comes up when you guys are rotating with us. Most often, it's going to be much more clear cut than this. I created this question to make it more engaging and have this conversation. Most of the times, it's going to be high calcium, PTH is high above the reference range. However, there is up to 20% of the patients where the PTH comes back normal based on the assay's reference range. And so what do you do in those situations? Most of the experts will tell you when you have a patient, you're working them up for hypercalcemia, if the PTH level is greater than 30, that's abnormally normal, right? If your calcium is 11.3, you shouldn't have any PTH secretion. And so that, in that scenario, we would confidently tell you that's abnormally normal PTH levels. If it's less than 10, all of us will tell you it's suppressed. It's not probably a PTH mediated pathway. The gray zone is when this PTH comes back at 20 and you're like, oh, what do I do? Is this PTH mediated or not PTH mediated? And this is why I put this question like this, because I wanted to have an opportunity to tell you, if you get a patient and you're working them up either inpatient or outpatient and the calcium is 11.6 and the PTH comes back 20, it is totally fair to call endocrine for an opinion or their advice or what they would do or what they think is happening. I think sometimes we get nervous to call the consult teams or ask for help. And I just wanted to highlight, this is a scenario we would be happy to help you guys because it's not straightforward all the time. Okay. And so there's that gray zone, and I want to acknowledge it when that PTH comes back like 20, 25, which way is it, PTH mediated or not? So that's the first pearl. The second thing, let's talk about what is this inactivating calcium sensing receptor mutation and what is FHH. So remember, if you've got an inactivating calcium sensor gene mutation, that means it's not sensing the calcium. And so it keeps secreting PTH from the parathyroid gland. And the other thing is, remember I said you've got calcium sensing receptors on your kidneys. So what happens is it keeps reabsorbing all that calcium, and you've got very little calcium excreted in your urine. Hence the name familial. So it's an autosomal dominant with a high penetrance. Hypocalciuric, so very little calcium in your urine. Hypercalcemia, high serum or plasma calciums. And it's a rare entity, but we always check our 24-hour urines when we're dealing with a PTH-mediated hypercalcemia workup, just to make sure we don't, the rare situation is if you don't check the 24-hour urine and you send a patient with this inactivating mutation gene to the surgery, right? Surgery is not going to help if you take out one gland because they have a calcium sensing receptor mutation. And so that's why we always check our 24-hour urines. And typically these patients are not symptomatic. They're not really presenting to the ER with high calciums. And then the other pearls are usually their calciums in their urine is very low. Less than 100 milligrams is sort of where my cutoff and most of the experts will tell you. And when you do the math for the fractional calcium excretion, it usually comes out less than 0.01. And then you can fairly confidently say, this is someone that we need to think about FHH for. However, I want to acknowledge that there can be some gray zones. And in this patient, I kind of put it in the gray zone, right? I put that fractional calcium excretion to throw you off a little bit. But again, you have to kind of take a step back and think about the whole clinical picture, right? You've got an older lady coming in. I told you there's no family history, even though I know getting a good family history can be hard. And again, her urine calcium is not less than 100 milligrams. And so that's why, for those reasons, I would probably still say that this is not FHH, and this is most likely still primary hyperpara. But the other thing I do want to acknowledge is if you're not sure, and if you're not sure how to interpret the 24-hour urines, and you do have a young patient, again, totally fair to consult endocrine or have them refer to endocrinology to make that decision and help you guys, because there is no consensus on this. And when to check for the calcium sensing gene mutation is also not there in the guidelines. It's kind of using the whole gestalt, the biochemical and the family data. Often I'll tell my fellows and the residents that rotate with us, if we do have a young patient and we've even, checked 24-hour urines twice, and we're still not sure, that's when you would consider genetic testing just to be sure, especially if it's not all adding up. Good. Some of you said it's her thyroid. Does anyone maybe want to unmute or maybe say in the chat box, why do they think it's not her thyroid that's causing the hypercalcemia? Any idea? Not sure? Couple things. Remember that PTH is abnormally normal, right? I specifically put it in that range. I didn't put it in the gray zone. And so if you guys think back, right, the two main branch points are PTH mediated or non-mediated. And so I didn't give you a suppressed PTH where you're going down this whole other pathway where you're either thinking malignancy, if you guys remember, versus the granulomatous, and then looking at the metabolites, or these rare things where then you're thinking about her thyroid. And the other caveat is I didn't give you a patient in thyroid storm. I think somebody said her active T4 hormone is normal. I didn't give you a patient who's presenting with thyrotoxicosis where she has elevated free T4. And so I purposely framed it like that. When you do have patients in thyroid storm or thyrotoxicosis, there are thyroid receptors on your osteoclast, on your bone. And so you can get mild hypercalcemia in a thyroid storm picture. But this patient's not presenting like that. She's not presenting with palpitations, elevated heart rate. She's not presenting with diarrhea, significant weight loss. And then again, her free T4 was normal. And so with that, we're not going down the whole suppressed PTH pathway. And likewise, the other choices was malignancy. Again, her PTH is not suppressed. So, and I didn't give you anything else to kind of go down that pathway, but mainly it's the PTH that helps you kind of determine which branch points for your differentials. Cool. So we used that lady to talk a lot about that PTH mediated and non-mediated and kind of the pathways and the workup and FHH. And so now I'm going to go into the second clinical question. So this is a patient who you're probably going to see more often, right? So this is a 69-year-old male. You've got a calcium of 11.9, albumin's normal. PTH is clearly elevated. So arrows going up for the PTH, 126. The phosphorus is low. The cutoff is 2.3, I think, in the normal range. And so remember your arrows. Calcium is up, PTH is up, phos is down. This is most likely what you're thinking is a primary hyperpara patient, right? The 24-hour urine collection is also not showing any low calcium or anything like that. This is a male that comes into the ER because they're not able to take care of themselves at home. They're nauseated, throwing up, and there's also a question of altered mental status. While the ER doc is trying to rule out other things, they want to admit them to the medicine team, so they called you. And your first question to them, or what do you hope that they've done in terms of treatment for this patient who may be confused a little bit as well? So do you think the first and most ideal treatment is calcitriol, A, B, IV fluids, C, Lasix and cinacalcet, or D, pamidronate? Pamidronate, for people who don't know, is one of the IV bisphosphonates. The two forms of IV bisphosphonates are pamidronate and zoledronic acid. Any takers?
I'm not seeing anything just yet. Give people a second.
Sure, Tess, thank you.
Some votes for B, a couple votes for B. Wow, lots of votes for B.
Yes, yes.
Takers.
Great. No, that is the best and the first thing that you guys should think about. It's IV fluids in these patients. And we'll talk about that and the other answer choices. So good. Just to highlight, there's no specific sign or symptom for hypercalcemia. I'll be honest with you, most of these patients, I see them both in the inpatient and outpatient setting, and there's a pan review of systems that's positive. A lot of them will describe to me a memory fog kind of a feeling where they're just not, there's something off. They can't remember things. They're not sleeping well. A lot of them will present still with the classic finding of nephrolithiasis, and it's a kidney stone. And then we find out they have hypercalcemia. They have muscle cramps, just myalgias, and so forth. And a lot of them will tell me that they're peeing a lot. And so one thing to keep in mind is, and we don't know the mechanism of this, but when you're having patients with severe hypercalcemia, they can have this component of nephrogenic diabetes insipidus. Uncoupling of the vasopressin receptors, and you get this significant water diuresis. And so these are patients, especially when they come to you because they're not feeling well in the ER, they are intravascularly volume depleted. And so that's why the first and foremost thing I want to emphasize is the IV fluids first. And it does take several liters for some of these patients. And that also allows passive reduction of the calcium and excretion of the calcium too. So it helps. The other thing I want to mention is just make sure you look at those EKGs on those patients that you're admitting, especially if you have a hypocalcemic patient. And hypocalcemia causes a prolonged QT. Hypercalcemia causes a shortened QT. This one is more worrisome for being prone for arrhythmias. So just something to also keep in mind. So the treatment, as I said, first and foremost is going to be IV fluids. And then what happens sometimes is if you've got a really symptomatic patient, and I'm talking about a calcium of 13, or they're not even talking, they're very altered, sometimes you'll see endocrine recommend calcitonin just quickly as a bridge. Calcitonin, again, we don't understand its precise mechanism, but it does definitely work on the osteoclast to help inhibit the calcium release. It's given sub-Q most often or nasally, and it works fairly rapidly to lower the calcium, but it's very short-lived. It'll come right back up, your calcium. And so only in severe cases do we use calcitonin as a bridge, but most often what we do is IV fluids and then the bisphosphonate. And so the two bisphosphonates, depending on which hospital you are at and the formulary, is pamidronate and IV zoledronic acid. One little tip, the serum calcium may take about 4 to 7 days to come down, but I promise you it'll come down eventually. It just sometimes doesn't show right away in your chemistry panel. And then just another word to keep in mind, if you're dealing with a patient with known sarcoid who's coming in with hypercalcemia, the treatment then is corticosteroids to decrease the 1-alpha hydroxylase activity and that conversion from inactive to active vitamin D. And then finally, I like to still mention it, with the advent of bisphosphonates, we really rarely use loop diuretics in the acute treatment of hypercalcemia. You may use it afterwards if the patient, has a little bit of increase in oxygen requirement or might be, a hit patient with heart failure. But it's no longer used as the first and foremost treatment. If you ever look at the literature, there are varying doses of loop diuretics given. I mean, 100 milligrams IV infusions. And as you guys would probably appreciate, they can cause a lot of metabolic derangements. And so with the advent of bisphosphonates and being efficacious, we don't use loop diuretics anymore. And so I've talked to you about bisphosphonate and the role of it in hypercalcemia. Just to briefly say the mechanism, and I'll definitely talk about this when I think I come back to give the osteoporosis core teaching talk. Bisphosphonate, what it does is it inhibits this key branch point enzyme in your osteoclast, and that way it kind of impairs osteoclast function and causes apoptosis of osteoclasts, which are your bone breaking down or resorption cells, right? And so if you don't have osteoclasts to break down, you don't get the calcium release, right? And so that's how you prevent hypercalcemia. Another one I just want to mention, especially for the wards and for the HEMONC rotations, right? A lot of your patients are going to come in with non-PTH mediated hypercalcemia or malignancy related hypercalcemia, like your lung or your bone mets patients. And again, kind of the same concepts, IV fluids. If you need a bridge, calcitonin, but mainly it's going to be the bisphosphonates. I put the doses here of the calcitonin and glucocorticoids if it's a lymphoma or something like that. But let's just say you have a refractory hypercalcemia patient where you've done all of this and their calcium is still high and they're symptomatic. This is, again, very appropriate to call endocrine because we don't expect you guys to pull out this last arsenal that we have, which is called denosumab. I hope some of you are familiar with denosumab. It is a medication we do use for osteoporosis and fracture prevention. At different doses, you can use it for refractory and severe hypercalcemia. And so just wanted to mention briefly what is denosumab and how does it work for refractory hypercalcemia. You've got several steps that leads to mature osteoclast formation. Especially, you've got this rank ligand protein binding to the rank receptor and activating this. Denosumab is a monoclonal antibody that inhibits this step. So you don't get osteoclast formation, function, and survival. And again, you don't get the osteoclast cells to break down and release hypercalcemia. So that's how denosumab works. Again, refractory hypercalcemia, you probably should call endocrine. You shouldn't be, we don't expect you guys to give that dose on your own. Oncology does sometimes because they're very familiar with the dosing for denosumab. Cool. So we've talked about management, inpatient, and all that stuff. Now I'm going to turn towards a little bit more outpatient question, and in this clinical case scenario. This is a 60-year-old female who you want to refer to from your primary care clinic to endocrine for a discussion of if she needs surgery for possible primary hyperpara. So you already suspect it's possible primary hyperpara. She tells you that she doesn't think she's had any kidney stones or fractures that she knows about. She had menopause at the age of 49 and never been on hormone therapy. She gets some calcium from her milk and from her cheese, but no other supplements. And there is no family history of calcium issues. Let's just say this is a face-to-face visit and the nurse got the height vital signs, and she's about 3 inches shorter than her reported height, interestingly. And you even had her pull out your driver's license to check the height. On exam, most of her exam is normal. The only thing that you noted was she has this mild thoracic kyphosis, kind of curvature. And so these are our labs. And so again, this is a patient that you're suspecting is primary hyperpara. You've got an elevated calcium, FOS is normal, PTH is elevated, and her fractional calcium excretion is not low and it's high. You have an old DEXA scan that's within the last year, and these are her T-scores, okay? So my question is there anything that you want to do or your next step to determine if this patient is a candidate for surgery for parathyroidectomy before you send them to the endocrine referral, because it's going to take them some time to be seen in the endocrine clinic? We have a backlog, let's just say. And so what do you want to do as your next step? Do you want to A, get some anterior posterior radiographs of her T and L spine? B, do you want to get a measurement of her ionized calcium? C, do you want to get genetic testing for the calcium sensing receptor mutation? D, do you want to get a parathyroid seismotiby scan? Or D, E, you want to get an ultrasound of the neck?
So vote for E, the ultrasound of the neck.
Okay.
And another vote for D, a couple votes for D. Yeah, it looks like E and D.
E and D, okay. I am so glad I put this question in. So first and foremost, I want to highlight that the diagnosis of primary hyperpara is a clinical diagnosis, okay? You don't need the seismotiby scan to identify which parathyroid gland is probably larger to say this patient has primary hyperpara. And the reason I bring that up is usually you get that scan if you know and you've already had a discussion that the patient wants to go to surgery. So it's for basically surgery planning purposes. And so I wouldn't jump to that quite yet. What I was hoping that you guys would say, but I'm glad you guys didn't, because then that means that I'll definitely be back in December to really do the osteoporosis talk, is I gave you some clues that she's had about 3 inches height loss, so anything more than 2 inches, as well as I'm telling you she has a little bit of kyphosis. And so my bell should be ringing that, hey, yes, this patient has told me that she doesn't have a fracture. Yes, her T-scores are not less than 2.5, but there are enough flags where I should get the radiographs to make sure she hasn't had a silent vertebral fracture. And so key points. Not all fractures are going to present where the patient classically bends down and they hear a pop or pain or something like that. And so I think the biggest thing to take away from this is, a lot of times the fractures can go undiagnosed. And if we don't have an idea and there's enough clues, we should look for them. And simple radiographs would be quite simple for her to get. And the reason I say to get the radiographs is there's certain criteria where we say the patient meets surgical criteria for parathyroidectomy versus there is this subset of patients where we just monitor. They're asymptomatic and you can monitor them. And so right now our calcium is 10.7. So it's not above the 1 milligram per deciliter above normal. It's not 11.2 or above. So she hasn't met criteria for surgery there. Yes, her DEXA doesn't show a T-score of less than minus 2.5, but let's just say her x-rays showed a fracture that you didn't know about and she didn't know about, then she actually would meet criteria for surgery, right? What's the definition of osteoporosis? T-score that's less than 2.5 at the major fragility sites or a clinical history of a major fracture. And we'll definitely go over that when I come back. The other criteria is her EGFR. Her EGFR is fine. It's not less than 60. She doesn't have 24-hour urine calciums that are elevated or a history of kidney stones, no prior CT scans that show the stones, and she's not less than 50. So right now, if her x-rays came back and showed you that she didn't have a fracture, she doesn't meet criteria for surgery. So then there's no need to get the seismotibia or the parathyroid scan, or even the ultrasound of the neck, right? And so that's why I put that in like that, to mention these clinical points and which patients meet criteria for surgery versus which patients can be monitored. And then the second thing, there's something missing in our DEXA scan. It is a forearm bone density scan. And so I wanted to bring this up. For unclear pathophysiology, what we do know is when you have high PTH, right? I've explained to you that there are PTH receptors in the bone, and there's this complicated pathway that gets activated, and you get breakdown of your osteoclasts, causing catabolic effects on your bone mineral density. And what we know, and again, for unclear mechanisms, is this high PTH targets specific sites of your skeletal system. It affects the cortical bone, especially in your forearm and in your hip. So there's two types of bone, trabecular and cortical bone. Cortical bone is very hard, compact bone. It's mainly distributed in the hip and in your forearm at 1/3 radius. Trabecular bone is very sponge-like with rods and plates. And it's created like that to really hold a lot of strain versus cortical bone holds a lot of weight or stress. And your spine actually has a lot of trabecular bone. And so this is the reason why when we see these patients in endocrine, we are particularly asking for a forearm DEXA, because studies have shown in patients' bone mineral density with primary hyperpara, and if we're looking at percent reduction of the bone mineral density, most often it's that 1/3 radius or the forearm site that's affected, then the hip, and then the lumbar spine. Okay. There are scenarios where all three sites are affected and the patient meets criteria for surgery. And then there are scenarios where only the 1/3 radius is reduced and has a T-score of less than -2.5, and they still meet criteria for surgery. So in this patient also, they didn't get a forearm, a bone density scan. So that would actually really help out your endocrine colleagues if you got that too. And the reason I also mention this is osteoporosis case detection screening is a passion area of mine, because I don't think we do a good job in case detection and screening. I think it's, and for no reason or fault of anybody's, I think, when these patients come in, right, they have all these comorbid conditions, and they're coming in and they're talking about their pain, they're talking about their blood pressure, they're talking about their diabetes. And so osteoporosis screening kind of falls down. But the reason I wanted to mention is as we're looking towards, racial disparities in our chronic disease states, I found this article which was looking at impact of race on presentation, the pre-op evaluation, and surgical outcomes for patients undergoing parathyroidectomy for primary hyperpara. And it is only a single center cohort study. And so, more research is needed. Most of the patients were Caucasian, but of the African-American patients, what was interesting is a lot of them had lower rates of complete preoperative evaluation, including the DEXA scan. So a lot of them were taken for the parathyroidectomy because they met other criteria, and no one checked their DEXA scan as well. And the other reason I bring this up is while African-American women have lower rates of hip fracture compared to the Caucasian women, they have higher morbidity and mortality. There's studies that have shown that they are often going to the nursing homes and so forth. And so we'll definitely talk about this more, but I wanted to bring this to your attention because you guys are seeing these patients doing part of this preoperative evaluation workup. So please don't forget that, with hyperpara, there is that whole integrated, osteoporosis and bone density that's also can be affected, and we should look for that in our patients. What they also did see was that their glands, the African-American patients' glands, were larger in size and mass. And so they weren't sure if that perhaps meant that they presented with more severe biochemical disease than their Caucasian counterparts. But fortunately, in this one single center, the operative success was similar. And so they were cured, and raw PTH did come down in all of the patients equally. Okay, good. Final case, and then we can kind of open up the forum to questions. Hopefully I'm doing okay on time. I'll try my best. So here is a 27-year-old woman. She has a 3-year history of nephrotic syndrome. And so she comes to establish care with you. And these are some of the labs that you're looking at and scrolling through. So you see your serum calcium of 7.8, a creatinine of 1, and a phos of 2.6. She tells you she has no paresthesias or muscle cramps, but on exam, she does have 2+ bilateral pitting edema, and she tells you this is not new. This is always there. And so which of the following labs should you check or obtain that would be most helpful for you to determine what's going on with this low serum calcium that you just got back? And the reference range, again, is 8.2 to 10.2 in most of the labs. Do you want to check a serum PTH, a serum 25 dihydroxyvitamin D, a serum albumin, a serum 125 dihydroxyvitamin D, or 5, a serum magnesium?
There's a vote for 3.
Yeah.
People want to vote for albumin.
Okay, yeah. Great. This is taking you guys all the way back to my initial slides. So good. Where when you have that serum calcium, remember it's just a total calcium. You need that albumin to double check, are you really dealing with a low calcium or not? And the other buzz that I gave you here is she's got nephrotic syndrome. So most likely her albumin is going to be low. And when you correct for it, the calcium will come back in that reference range. So yes, albumin first. Let's say you check the albumin and it comes back, but the calcium is abnormal in another patient, then the next step is absolutely the PTH, because it's going to help you again with the differentials, right? In a low calcium state, your PTH should be high. If it's not, then there's an issue with the parathyroids, okay? And the most common scenario that you'll come across is a post-surgical patient. They've just had head and neck surgery, especially a thyroid surgery. And there's sometimes this phenomenon where you temporarily stun the parathyroid glands so they don't release the calcium. And so that's the most common scenario you'll encounter. But if the calcium is low, your PTH should be high. And so if it is high, that is appropriate. And so then you need to look for other causes, not the parathyroids. And so could it be renal issues or malabsorption or so forth, or in this patient, like a nephrotic syndrome picture where you've just got other reasons going on. So good. So what's happening in hypocalcemia? A low calcium actually means an increase in the permeability of the action potentials and depolarization. And so that's why you have the perioral tingliness, you get in severe situations, the spasms, seizure, tetany, and arrhythmias. So just something to keep track of when you're thinking about the signs and symptoms. And the picture showing you the classic Schaaf stick sign, where you kind of tap your anterior part here, the facial nerve, and the patient kind of does that twitch. It's not a specific sign. There is a population of patients out there that have this that's positive, and they don't have calcium issues. So it's just something to keep in mind. The other sign that's a little bit more specific is, you guys remember right from medical school, the Trousseau sign, where you inflate the blood pressure cuff and leave it inflated for about 3 minutes, and the patient's hand will start doing a very funny contracture. I've only seen it once when I was a medical student back in the day, when we were seeing a post-op patient. And I haven't seen it since, even though I've seen low calcium patients. I think it's also hard because it is hard to find those blood pressure cuffs these days. So just something to keep in mind. Like I said, most of them are post-surgical patients, about 75% of the patients when you're looking at the causes of hyperparathyroidism. a good portion of those patients, it'll be transient. Usually we can taper them off very carefully. Their calcium supplements, their vitamin D supplements, and they'll do okay. But there are a subset of patients that unfortunately their parathyroids don't wake up. The surgery caused some issues and they chronically have to be on medications. And so this can be quite burdensome for the patients, I'll tell you that. And usually it is managed by endocrinology, given the complexity in the regimen that they have to take. And then this is just the breakdown of, often I've seen this when the patients have had total thyroidectomies in my experience, less when it's a partial or a hemithyroidectomy. And then there's the much rarer causes where it could be autoimmune, it can be genetic, it could be an activating calcium sensing mutation gene, or it could be something where there's a mutation of the regulation gene, and you can have something called autoimmune polyglandular syndrome, or APS type 1, where they're kind of presenting with this oral candidiasis, hyperpara, adrenal insufficiency, and gonadal failure. So, but much rarer to have that presentation. I think usually house staff and even my fellows are a little less comfortable managing the acute kind of that urgent setting of the calcium. So I wanted to mention that. The two main things that you'll give right away that are in the Pyxis carts are usually calcium gluconate and calcium chloride. I heard recently calcium chloride was maybe at Harborview, just something that it can cause vein irritation, and usually it's given through a central line, not peripherally, but either one is fine. The calcium chloride does have more elemental calcium in it than the calcium gluconate. But in a situation when you have a patient and you've got a true hypocalcemia and they're having, let's say, seizures and something like that, just giving 1 or 2 amps right away of calcium gluconate or calcium chloride is the best thing to do. Followed by probably they need a drip. And, you know, what I've put here in bold is kind of my cocktail that one of my nephrologist attendings actually told me, where you just tell pharmacy, take 10 amps of calcium gluconate and dilute it in a liter of D5W or 0.9 saline and just start the drip. And most of my fellows throughout the years have used this and it works. So there is complicated math, but in the middle of the night, right, it's hard for them to do that. And so I've told them, try this out and it'll work. The other thing to keep in mind is when there is something else, but we don't understand the pathophysiology, where if the magnesium is low in these patients with hypocalcemia, they're going to have something called PTH resistance and their calcium cannot be corrected. And so often I just tell patients, you know, even if you're trying to wait for the magnesium to come back, just give the magnesium. And usually you have to give the magnesium sulfate because as you guys know, the chemistry panel doesn't have magnesium right away. It's something you have to order. So something to hopefully get you guys thinking about when you have a hypocalcemic patient on the floor. And I think for the sake of time, I will kind of stop there and I am available for questions. Hopefully this kind of helps you kind of think about these patients and how to work them up and all the feedback loops and some of the management and that you guys will use this to build on this throughout the year. So thank you guys so much. And I'm here if there's questions.
Thank you so much, Dr. Narla. If anyone has questions, definitely please pop them in the chat. We can hang for a minute and just make sure.
Yeah.
Nobody's got anything lingering. That was great though. Thank you.
Hopefully the patient you told me about with ultramental status didn't have hypercalcemia, or did they?
They did not. No, that was not ultimately their problem, but it was a helpful primer for our talk today.
I know, that worked out well.
I'm seeing a lot of thank yous in our chat, but no questions just yet.
We're happy. We get a lot of these consults on all 3 of the sites, you know, hypercalcemia for primary hyperpara, for refractory hypercalcemia. And so you'll see this quite a bit that'll come up. And even in the outpatient setting, because the chemistry panel has the calcium, we're picking up more of these elevated calcium sooner. And so it'll definitely come up in your outpatient settings too. So we're happy to help.
Awesome. I'm not seeing any questions. So I think, and our group is slowly
You have to go back to the wards, right? Yep.
Awesome. Thank you so much. I really appreciate it. This was a great talk. And if everyone who's left, please fill out our survey through that link or through the QR code. Thanks so much, Dr. Narla. Have a great rest of your day.
Bye, everyone.